Hey everyone, welcome back to Izzy Medicine, where we decode the chaos of clinical medicine one cytokine at a time. Today, we're diving into obesity and metabolic syndrome. It's a topic that shows up everywhere, from clinic visits to hospital floors, and it's one that ties together endocrinology, cardiology, hepatology, even pulmonology. So let's discuss. Imagine that you have a 48-year-old man that walks into your clinic for a routine checkup. During the visit, he tells you that over the last couple of years, he gained a bunch of weight, and he noticed that it's especially significant around the belly area. And he says that he's been feeling much more tired lately. He feels like when he wakes up, he hasn't rested at all. He mentions that his wife keeps nudging him at night because he snores so loudly like a freight train. And he also noticed that he's getting more out of breath lately and a lot more easily than before. So you do the exam. And on vitals, you notice that his blood pressure is elevated at 138/88. And you also decide to measure his waist circumference, and it's 43. You order some labs, and you gotta wait for them. So before you even look at the labs, your mind should already be lighting up, thinking, is it possible that it's metabolic syndrome? A couple days later, you get the labs back, and it shows a glucose of 112, which is elevated, and triglycerides that are elevated at 180, and a low HDL of 36. So now you're saying probably it's metabolic syndrome. But the question is, what is metabolic syndrome? What is happening to our patient? Why has he gained weight? Why is his sugar elevated? Why are his triglycerides so high? What's happening? So let's discuss where this cascade begins. What happens is it starts when caloric intake exceeds caloric expenditure. So when there's more consumption of food and not enough burning of energy, the body takes all that extra energy and it stores it. And that energy gets tucked into adipose tissue. At first, the fat is deposited subcutaneously under the skin. And even though subcutaneous fat isn't exactly harmless, it's not the main problem. What happens eventually to the subcutaneous storage, the depots fill up, and the body starts placing fat viscerally around the organs like the liver, the intestines, the kidneys, the pancreas. And this is where things start to get dangerous. Visceral fat is a metabolically active. It's not just storage. It's a source of constant signaling. It releases chemical messengers called adipokines that enter the circulation and they start affecting tissue throughout the body. And additionally, because this fat drains into the portal system, the liver gets hit especially hard by these signals, and we'll discuss this shortly. Let's break down these adipokines and what they're actually doing so we can understand what is getting signaled and where the symptoms and signs are coming from. First up, we have leptin. Leptin is the satiety hormone. It tells our brain, hey, we're full, stop eating. But what happens in obesity is leptin levels are chronically elevated. And over time, as leptin is secreting, the brain's not responding and it becomes resistant to it. So despite all the leptin shouting, the brain's just not hearing it and not responding. Appetite stays up, satiety signals are blunted, and the patient is constantly eating, which promotes more weight gain. Why does this resistance happen? The thought is that chronic inflammation that's possibly within the hypothalamus, as in addition to impaired leptin transport across the blood-brain barrier, are both interfering with the brain's ability to respond. Then we have resistin. This is one that interferes with insulin signaling. It acts at the insulin receptor level and it blocks the cascade that normally moves glucose transporters like the GLUT4 to the cell surface. So even though insulin is present, glucose can't get into the cells effectively and efficiently, and this is one of the key drivers of insulin resistance. We've discussed adipokines in our diabetes mellitus lecture. And again, think of insulin resistance like the key that no longer fits in its lock. The key is insulin. It's there. But the door, the cells won't open to let glucose in because of this adipokine resistance. Then we have our inflammatory cytokines, TNF-alpha and interleukin-6. TNF-alpha is not only responsible for blocking insulin signaling, but it also activates stress pathways in the cells and it contributes to systemic inflammation. Interleukin-6 ramps up liver production of acute phase proteins like CRP, and it also perpetuates chronic low-grade inflammation throughout the body. Lastly, there's adiponectin. which is great because it normally enhances insulin sensitivity and has anti-inflammatory effects. So technically it should balance any inflammatory processes and insulin resistance that there is. But, and there's a but, in obesity, adiponectin levels drop. So not only is inflammation rising from all the other mediators, protection is dropping at the same time. These messengers reach almost every system in the body, and that's why our patient has a myriad of symptoms. So now let's talk about why our patient has blood pressure issues, because we kind of reviewed why the glucose is elevated from insulin resistance and why potentially the patient is tired from all that inflammatory process. What happens with blood pressure is that fat cells, especially the visceral ones around the organs, they produce more angiotensin. Angiotensin is the precursor to angiotensin 2. We've discussed this in previous lectures. This kicks in the renin-angiotensin-aldosterone system into gear. And angiotensin, what it does, it constricts blood vessels and it stimulates aldosterone release. And aldosterone causes the kidneys to hold on to sodium, retain it, and retain water as well. So what we have now is, because of angiotensin 2, we have blood vessels that are constricted and tight. And because of aldosterone, we have blood volume that is increased. And this contributes to hypertension, constricted vessels with higher volume. Now, that's not all the causes of hypertension, of the elevated blood pressure. Leptin and interleukin-6 also stimulate the sympathetic nervous system. So we know when the sympathetic nervous system is stimulated, that means more epinephrine and norepinephrine. So what happens is norepinephrine acts on alpha-1 receptors to tighten blood vessels even more. And it also acts on beta-1 receptors to increase heart rate and cardiac output. We also discussed this in various lectures, including the pheochromocytoma lecture, where there's excess norepinephrine. So blood pressure rises from both volume overload and vascular tone, and that's how obesity and metabolic syndrome crank up hypertension. So now we understand why there's elevated glucose and why there's blood pressure issues. Now let's talk about the liver. Why do we have high triglycerides? Why do we have low HDL? Why is the liver at risk? So our poor liver, because the visceral fat drains into the portal system, the liver gets directly exposed to all these free fatty acids and the inflammatory signals. What happens? This leads to hepatic steatosis, or fatty liver, or fat accumulating in the hepatocytes. And what the liver tries to do to protect itself, it tries to package and export some of that fat as VLDL particles, which raises triglyceride levels in the blood. So this is where our high triglycerides come from. At the same time, HDL, the good cholesterol, it gets broken down more quickly and produced less efficiently. So now we end up with high triglycerides and low HDL, which is usually protective and kind of the cleanup system. And this is the classic dyslipidemia of metabolic syndrome. Unfortunately, in the liver, if the inflammation persists, that simple steatosis can turn into NASH, which is non-alcoholic steatohepatitis. And here, there's hepatocellular injury and immune cell infiltration, and the hepatocytes get more and more damaged. And unfortunately, over time, if this cycle continues, we can get a fibrotic liver. Fibrosis can set in, and that can progress to cirrhosis eventually. And this is how cirrhosis develops in a patient who's never touched alcohol. And that's super serious ramification of metabolic syndrome. That's not our last system. We also have our lungs, and this is probably where our patients' difficulty with fatigue and with shortness of breath comes in. So let's review. The extra fat, it doesn't just mess with metabolism, it physically weighs down the chest wall and compresses the airway. So around the neck, if the fat builds up, it narrows the upper airway, especially when the patient is laying down. And that leads to obstructive sleep apnea, which we discuss in a separate lecture. But obstructive sleep apnea is characterized by snoring, which is why his wife is nudging him at night. Apnea episodes, which is the patient stops breathing in the middle of the night. And because of that, the cessation of breathing creates frequent nighttime arousals and lack of oxygenation. And in turn, the patient wakes up feeling completely unrested because not only were they deoxygenating, they were also waking up repeatedly, constantly from the episodes where they stopped breathing, or possibly their wife nudging them because they're snoring so loudly. There are more severe cases where fat around the abdomen and chest wall restricts the ability of the diaphragm to contract fully. And what happens is this leads to hypoventilation, not just at night, but during the day too, which may be why our patient is having a difficulty breathing or feeling short of breath, in addition to possible other ramifications of obesity that can cause shortness of breath that we would need to evaluate. But in this case, the patient may be retaining CO2, oxygenation drops, and that is called obesity hypoventilation syndrome, and it can really lead to chronic respiratory acidosis if we don't address it. As if this is not scary enough, all these issues that our patients dealing with, high sugar, high blood pressure, having obstructive sleep apnea, not oxygenating, not resting, what is even more scary is that all of these things increase the risk of cardiovascular disease. High glucose leads to glycation of LDL, and that makes it more likely to get trapped in the vessel walls and form a plaque. Low HDL means that we don't have that cleanup system. High triglycerides add to more fat circulating, and it adds to the load of arthrogenic buildup. And over time, what can happen is these plaques can rupture. It can trigger events like myocardial infarction, a heart attack, or a stroke, or peripheral arterial disease, where all of these plaques are in the lower extremities, and they can cause claudication, significant pain with walking. And at other times, if it's completely blocked, it can cause limb-threatening ischemia, where patients can lose toes or even feet, or even half of a leg because of these complications. So this patient, he didn't come for any of this. He didn't know that that's what he's coming for. He came because he's tired and he's gained weight. But his waist and his labs and his blood pressure and his symptoms, they're all pointing to a much bigger story. And that's where being attuned to the puzzle pieces that I love so much is important. The good news for the patient, even though this kind of sounds very dire, is that we can intervene, we can help. Because at the end of the day, this isn't about losing weight for vanity. And I tell that to my patients all the time. Weight loss is not for vanity's sake. If you're healthy and a little heavy, we can work on it slowly if you want to. This is more about reducing organ damage. It's preventing long-term complications, and it's helping the body restore balance. So we kind of alluded to all the criteria for diagnosing metabolic syndrome, but let's break it down just so we understand specifically what the criteria includes. Waist circumference over 40 inches in men or over 35 inches in women. Triglycerides that are elevated over 150. HDL under 40 in men or under 50 in women. And a fasting glucose of over 100, although that's from the American Diabetes Association, but there are other associations that use slightly higher markers such as 110. But look at the overall picture that the patient presents with. And the last one is blood pressure over 130 over 85. We need 3 out of 5 to diagnose metabolic syndrome. Now, what do we do once we see this patient? What do we tell the patient? How do we help this patient understand? So all of these things can improve significantly. We can improve insulin resistance, improve lipid profiles, reduce inflammatory signals. Even with 5 to 10% weight loss can make a significant difference. I usually tell my patients that there's a bigger goal of a particular amount of weight loss that we should attain, but giving them a small goal of half a pound to a pound a week sets a realistic and attainable goal that they can attain and maintain. Because telling somebody you need to lose 30 or you need to lose 50 is very, very scary when they're already struggling. And then you can act as their accountability partner. Also, allowing the patient to lose their 30 or 50 or 20 pounds over a prolonged period of time, telling them that it's okay if it happens in 3 months or 6 months or a year, gives them, again, an attainable goal that they can work on without feeling overwhelmed. Because at the end of the day, yes, we do want things to happen quickly, but also the patient has a life and things that they're trying to do, and they can't entirely focus on this rapid weight loss. So giving them the psychological support and accountability buddy is very important. This is also where we can introduce a dietitian through a referral to help them work on the various different diets. And also, if they have a flexible spending account that can help get them somebody to help them with exercise, that is something that we can help incorporate. Speaking of diet, let's get specific about effective dietary approaches. So there are a couple of different approaches. The Mediterranean diet is rich in olive oil, fish, nuts, vegetables. It has shown significant benefits for metabolic syndrome. We have the DASH diet, the dietary approaches to stop hypertension. And this reduces blood pressure and improves insulin sensitivity. And both of these emphasize whole foods while limiting processed carbohydrates and saturated fats. For exercise, what I usually tell my patients is start with 5 minutes in one direction, walk away from the home, 5 minutes back. That's 10 minutes of exercise, brisk walk to the point where we feel a little bit uncomfortable, but not entirely too short of breath, and do that 3 days a week. Because even though that's not the goal of 30 minutes of exercise, it sets them up slowly, because telling a patient to exercise 30 minutes, 3 to 5 days a week, when they're not doing that, is very, very overwhelming. Not a lot of people can attain that easily. So 5 minutes away from the house, 5 minutes back to the house, really gets them home in 10 minutes, and they felt like they did something. I tell them once they feel like they're comfortable with that, like they're not winded anymore, increase it by 5 minutes. And then by 5 minutes, and by 5 minutes again, until we reach 30 minutes, 3 to 5 days a week. Additionally, as I alluded to, don't overlook the psychological aspects of obesity treatment. Addressing the fact that this patient is stressed because of their symptoms, that their sleep quality is diminished, and because they're so tired and so underslept, their mental health is probably suffering from all of this. Addressing that and acknowledging it and validating goes a long way in improving treatment adherence and outcomes. And in fact, the relationship between obesity and mental health, it runs both ways. Depression can lead to comfort eating and reduced activity, while obesity can worsen the mood through physiological pathways. And screening and treating depression and anxiety when we see the patient is struggling with food and weight should be a part of any comprehensive obesity management plan. Once we've addressed lifestyle changes, if it isn't enough, there are medications that we can utilize. So, for example, GLP-1 receptor agonists like semaglutide help reduce appetite, they improve insulin response, and they even slow gastric emptying, where the patient might feel fuller for longer and not overeat. And beyond the weight loss, these medications offer cardiovascular and renal protection, and they reduce major adverse cardiovascular events and progression of kidney disease, and that's why they've become so popular. They are costly, but if our insurance plan approves it, it's a great thing to start with to help our patient with metabolic syndrome. Other options include phentermine and topiramate, and this is a combination of a stimulant that suppresses appetite with an anticonvulsant that promotes satiety. We have bupropion and naltrexone, and they target both dopamine reward pathways and hunger signals. And orlistat, which reduces fat absorption in the gut because it inhibits pancreatic lipase. And each one of these have their own pros and cons, and we consider the comorbidities to guide selection. For example, for patients with type 2 diabetes, GLP-1 agonists provide glycemic control and cardiovascular benefits. For those with depression, the bupropion naltrexone combo may offer a dual benefit because we're helping with dopamine. And for patients with difficult to control hypertension, we gotta think about medications that don't affect blood pressure like orlistat, and that may be preferred. Additionally, for patients with more severe metabolic disease, we have newer therapeutic options that are emerging, and these are the dual GLP-1 GIP receptor agonists. And these show even greater efficacy for weight loss and metabolic improvements than just the GLP-1 agonists alone. What GIP is a glucose-dependent insulinotropic polypeptide. What it does is it works by enhancing insulin secretion and improves fat metabolism. So they complement the effects of the GLP-1, and that creates a more robust metabolic response. So that's pretty cool. In severe or resistant cases, we know that we can always proceed with bariatric surgery, but bariatric surgery isn't just for weight loss. What it does is it improves metabolic health. Whether it's a sleeve gastrectomy, a gastric bypass, or another approach, these procedures reduce hunger hormones, they improve insulin sensitivity, and they dramatically reduce complications. So let's recap the treatment. We do lifestyle modifications, medications, injections, and surgery. We try to match the intensity of the treatment to the severity of the disease, as well as addressing the root cause, as well as paying attention to whether our patient is successful with the initial treatments that we're implementing. and assessing whether they need more aggressive intervention or more aggressive explanation of the situation. Lastly, let's not forget about prevention. The old cliche is that an ounce of prevention is worth a pound of a cure. In obesity medicine, it's literally true. Prevention strategies include regular screening for weight changes and metabolic parameters, early intervention at the overweight stage, so talking to our patients, showing them their labs, explaining where their labs are trending, because you can show them a lab from 2 years ago and you can say, look, there are changes in your body that are happening and this is what your body is telling you. Let's try before we get more complex. Additionally, we have new things on the horizon, which are some of my favorite things. Current research is exploring the gut microbiome role in obesity. New medications target beyond the GLP-1. And then we have personalized approaches to treatment based on genetic and metabolic profiling, which is the field of precision medicine that I love so much. And I think that's going to be the wave of the future. And it tailors interventions to specific obesity phenotypes rather than treating everybody the same. And I think that that's amazing. And it's a field that I'm super, super excited about and actually do a lot in. All right, friends, that's a wrap on obesity and metabolic syndrome. I am very, very thankful for you being here and learning with me and for watching. And I hope that this helped clarify some things. If it did, hit the like button, leave me a comment so I can answer questions if you have any, and subscribe so you don't miss any of the fun, entertaining Izzy Medicine episodes. And as always, stay curious, stay kind. Don't ignore the waistline because it's telling us a story. And I'll see you on the next lecture. Bye.